Hypothyroid symptoms are extremely common. Fatigue, weight gain, hair loss, cold intolerance, constipation, and brain fog affect millions of Americans even when their labs appear to be normal. This is a major challenge for many providers and patients. In this short video, we are going to find exactly why some of your patients continue to struggle with symptoms of hypothyroidism despite their labs looking normal or them being on medication. I also wanted to share with you this interesting published study in the Journal of Endocrine Practice in 2024 showing us that approximately 1 in 4 patients with hypothyroidism and a standard of care prescription medication who achieves normal TSH levels experiences persistent or new symptoms related to hypothyroidism. Beyond the challenge of so many patients experiencing subclinical hypothyroidism, which means that they have symptoms long before their TSH level increases, which delays cares and leaves many of them feeling unwell despite their labs being borderline, the main focus of this video is to find why so many patients are receiving T4 therapies or occasionally compounded T4 or T3 blend, their symptoms continue to persist. And that's mostly because we are not addressing the root cause of those conditions. So let's dive into it. I'm gonna draw here on my whiteboard here, I'm gonna draw the thyroid. There are a few things that are going on here. We first have the stimulation of the thyroid secreting hormone, which most providers test. And then we also have here the 2 major hormones that the thyroid secretes, which are T4 and T3. Now T3 is also referred to as the active hormone. This is what is stimulating our receptors, right? So let's say this is the receptor on our cell. And so the T3 is going to get in here and going to stimulate the cell. Now, there's a few problems that we are looking at to better understand, we're going to discuss to better understand why our patients might continue to struggle with symptoms of hypothyroidism. We have to first understand the conversion. So when a patient comes to see you and you measure their TSH levels or T4 levels and you see that they have symptoms of hypothyroidism, maybe TSH is high, maybe T4, it's either high or low. But what we're measuring here, when you give them a prescription, you typically give them T4 or a compounded T3. Now, let's take a look at what one of the first major problems are. T4 is not an active hormone and it needs to be converted. So in order to be converted, we are using certain enzymes, right? Certain enzymes, for example, the D1 enzyme that is important for metabolizing T4 to T3. So there's a few things that we need to understand here. One, the conversion requires certain nutrients. If your patient is deficient in selenium or zinc, they might not convert this properly. And I'm giving you these as examples because, for example, zinc is important for the function of deiodinase enzyme activity. And there are surveys that are showing us, there's one survey published in the journal Nutrients in 2020, showing us that about 15% of the adults population in the US had lower zinc intake below the estimated average requirement. And zinc stabilizes the T3 receptors on the cells. So zinc is really needed for stabilizing the function of this receptor. And if you have zinc deficiency, then the active T3 is going to bind less effectively, right? So that's really, really important. The second thing we have to understand is that the conversion is happening in several places. The first place that we're looking at, and let's say the primary one, is the liver. So our liver converts about 20 to 40%, and then we have the gut. So the gut is another place where conversion is taking place. Why am I mentioning the gut? because both gut bacteria and the intestinal D1 enzymes play a role in this conversion. So, if your patient, for example, have what we refer to as dysbiosis, meaning they don't have sufficient of the beneficial bacteria, or they have an imbalance, which means lower beneficial bacteria or overgrowth of the harmful bacteria, there are many studies that are showing us the impact of this pathway of conversion. Next place that we have this conversion is the kidneys. The next thing that we want to talk about when we talk about the conversion is stress. So chronic stress, I'm going to put this here as one of our challenges. So chronic stress, every time we are stressed, our body activates the HPA, hypothalamic pituitary adrenal axis. That axis secretes cortisol. Cortisol does is interfere with the conversion of T3 to T4. So that's another mechanism. And we'll put all this together when we talk about treatment, what treatment recommendation or consideration we'll have in the end. You can see multiple things that can go wrong and reduce the conversion. We got gut dysbiosis or loss of function. If your patient have liver issues or kidney, if they have lack of nutrients, I would say more commonly selenium or zinc. And then if they continue to struggle with chronic stress or dysregulated stress response, that can also interfere. Now let's talk about this next problem that we're seeing, conversion of T4 to reverse T3. So T4 needs to be converted to T3. However, there is a hormone that is called reverse T3. I'm going to put it right here, reverse T3. Now, reverse T3 is not a metabolically active hormone, but what it does, it likes to take the place of the receptor, inhibiting the active T3, the active hormone T3, from plugging into that receptor, and therefore leading to reduced metabolic function in our cells. And so, what leads to an increase of reverse T3? So there are multiple things that can cause that. The first one is cortisol. So we already mentioned cortisol. Cortisol increased the conversion of T4 into reverse T3. So that will be cortisol. Cortisol stimulates that pathway. The second thing is inflammation. Inflammation stimulates the same pathway in taking from our T4 and converting into a reverse T3. Now, interestingly, you can test TSH, T4, T3, and you can still, the patient, even if the labs results are within their normal reference range, but your patient have elevated reverse T3, they can still struggle with the symptoms of hypothyroidism, because again, we have a hormone here that is being synthesized from T4 that is not metabolically active and takes the place of the reverse T3. Now, the next factor that is important for us to remember is that majority of hypothyroidism cases are caused by a chronic inflammatory and autoimmune condition that is called Hashimoto. And so when your patient has chronic inflammation, aka Hashimoto disease, that means that they have ongoing immune dysregulation. And what that does, it essentially causes less active T3 to reach the cells, because we mentioned again that the inflammation leads to more conversion of T4 to reverse T3. But the increase in cytokines that inflammation is producing, so increase in cytokines, this is the second pathway. Increase in cytokines reduces the number and sensitivity of the thyroid hormones receptors on the cell. So now we are getting damage to these receptors. It reduces their sensitivity, and as I mentioned, and the quantity of those receptors. If we do not address, if your patient is just getting prescription medication, either T4, or if you're doing hormone replacement therapy in a compound form, T3 and T4 together, and you're still not addressing these other factors, the nutrients deficiency, the ongoing inflammation, the chronic stress or dysregulated stress response and cortisol, right, their gut, your patient could continue to struggle with those symptoms. So, what do we do? So let's take a look at some of those labs that we want to focus on when we are doing. And this is, by the way, what we talk about a lot in functional medicine. So some providers ask me, is functional medicine holistic or alternative medicine? And my answer is always, it is a form of a health system. But what we're doing essentially is we're looking at the root causes and we're trying to understand why is the patient struggling with symptoms of hypothyroidism. Instead of trying to just manage those symptoms with prescription, we're trying to understand what's causing it, what's driving the dysfunction, right? And that's a big difference. And not to say that we don't need a standard of care. Standard of care is important for managing the patient's conditions, right? But when the patient wants to understand what's causing it, or you as the practitioner wants to understand what's causing it, address the dysfunction, and focus on health optimization, we need to look at the root causes. And these are 2 or 3 examples of the root causes. So let's take a look at this picture, which shows us which labs we would want to order. So the core thyroid function test we know is TSH, free T4, free T3. We also, of course, want to look at the conversion test, so better understand looking at free T3. We want to look at reverse T3. That's really important. That's going to give us additional information to see, is our patient's conversion not functioning properly, right? We want to look at markers of chronic inflammation. So we would want to look at CRP, C-reactive protein. We want to look at ESR. We can look at interleukin-6. That's another one that is involved in this, is another cytokine that is involved in these conditions. And then look at specific autoimmune thyroid markers, the TPO antibodies, the thyroglobulin antibodies, which will tell us what's happening in terms, is there damage, ongoing damage to the patient's thyroid, which happens in patients with Hashimoto. And then, of course, a few considerations for care. We got to support our patients nutritionally. So selenium, methionine, there's some really good studies that are showing us that 200 microgram a day can support conversion of T4 to T3, also reduce antibodies. So this is a pro tip for you as a practitioner. If you see elevated levels of the thyroid antibodies, 200 microgram a day for 6 months was found to reduce levels of antibodies significantly. Zinc picolinate is important, 15 to 30 milligrams per day to support the conversion. Also important for TSH signaling and receptor activity. Remember that for every 10 milligram of zinc, we have to provide a patient with 1 milligrams of copper. And then iron is really important to support TPO and thyroid hormone synthesis. And then mostly use if the ferritin levels are low. Vitamin D is great for supporting immune regulation. Iodine is required for thyroid function as to support hormone synthesis. And of course, don't go over 150 microgram per day. Look at your patient's diet to make sure that they're not consuming also dietary, or it's also not found in their multivitamin or other supplements they're taking. In total, they should not be taking more than 150 microgram per day. And then, very important, finding and addressing the root causes of inflammation or dysfunction. That's exactly what we're doing in functional medicine. So when I showed you the chronic stress and inflammation, what's causing that inflammation? What factors in the patient's environment, diet, lifestyle, internal factors such as gut microbiome, cellular dysfunction, what's driving that inflammation? Beyond that, we want to support our patient's gut. So that could be a high quality probiotic or prebiotic or symbiotic. That could mean for some patients testing, doing a comprehensive GI testing when appropriate. And of course, managing stress. That is so important to manage stress because every time your patient is stressed, they activate the HPA axis, which releases more cortisol, and we already talked about what cortisol is doing. So, nutrition, find the root cause of their chronic inflammation and dysfunction, and then gut health and supporting or managing their stress. All of these important, and they will help you to create a comprehensive treatment plan to get your patients to better health instead of just managing their condition. I want to thank you for watching this, and take care for now, and I'll see you in the next class.